Dear friends, today we will be discussing about how to report cytology FNAC smear or how to prepare a structured report of cytology. Cytology or FNAC, as you all know, is a very important first line investigation in laboratory practice. It was initially used as a means to confirm the presence of metastasis in a case of cancer without subjecting the patient to further surgical intervention. Later on, as the popularity of aspiration cytology increased and its applications increased, it started getting used in diagnosis of other conditions like inflammation, infection, degenerative diseases, graft rejection, and then came the period when it is used now as an alternative or complement to frozen sections. Another important use is intraoperative cytology to diagnose presence of malignancy and type of malignancy. With such a wide application of FNAC, let us go through the various methods which are used to perform FNAC. We can have superficial palpable lumps in the body, and these are aspirated using the conventional FNAC method of palpation and FNAC. Then there are deep-seated lesions in the body which are aspirated with the help of radiology imaging techniques, and these can be done under ultrasound guided guidance, that is USG guided FNAC, or the FNAC can be under CT guidance or mammography guidance or stereotactic needle guidance. So these are the various radiology operated FNAC methods. Then is the newer technique, relatively newer technique, that is EBUS guided DBNA. What does that mean? That is endobronchial ultrasound guided transbronchial needle aspiration cytology. And this is used for diagnosis and staging of pulmonary, hilar, and mediastinal malignant lesions, as well as for diagnosis of non-malignant lesions such as sarcoidosis, and this procedure is a minimally invasive procedure. And the latest is endoscopy guided intestinal FNA. In this, during endoscopy, FNAC is carried out in the masses which are seen in the lumen, projecting into the lumen, or they may be located in the submucosal region of the intestine. So these are the various methods being used for carrying out FNAC of superficial and deep lesions. Now, how to say that we get good material and that forms the basis of successful FNAC. So to have success of an FNAC, we have to depend on, there are four fundamental requirements for successful FNAC. Sample must be representative of the lesion which is being investigated. Sample must be adequate in terms of cells and other tissue components. Sample must be correctly smeared and processed. And the request for FNAC must be accompanied by relevant and correct clinical and radiological information. So these are the requirements to make your procedure successful. Then once the patient has come to your clinic and wants the FNAC to be done, the first thing to do is to take consent from the patient to carry out the procedure. This should be done before proceeding with the FNAC procedure. Consent should emphasize the importance of providing patient with adequate information about the procedure, how it is going to be carried out, about the accuracy of FNAC diagnosis, how this procedure is going to help the patient in getting a report which will help him in further management, limitations of FNAC, that there may be some cases where there may be failure and complications associated with FNAC, so that they can make informed decision about the FNAC procedure, whether to go in for the procedure or no. In cases of children and incompetent patients who cannot give their consent, parents or legal guardians are responsible for giving the consent for FNAC procedure. Now, where to take the consent? The consent can be typed on your own report form, and signatures of the patient or close relative can be taken. Relationship should be mentioned under the signature. This way, filing of consent becomes simple and easily retrievable in time of need. So there is no need to do separate filing of the consent form. It is with the report form itself. Then adopting good clinical practices is very important in carrying out FNAC procedure. The patient should be made comfortable by maintaining good, pleasant environment in the clinic. Staff must be trained in dealing with patients with courtesy, patience, and empathy. When patients come in for test, there is fear and apprehension in their mind. Proper counseling, engaging them in general talk, asking them about their problems, showing sympathy, and gentle handling helps in allaying their fears. They become more understanding and cooperative during the procedure. So you get better results and a happy patient. Now, diagnosis by FNAC or diagnosis in pathology in general is dependent on the clinical information you know, and knowledge of the clinical medicine is important to interpret the clinical information. So we should be good in clinical medicine and we should be good in our own subject to make a good, accurate FNAC diagnosis. What information we should know before we proceed with the procedure of FNAC? What is the site of the swelling? Because depending on the site, the diagnosis and the differential diagnosis, they vary. Whether the swelling is single or multiple. Lymph nodes can be multiple, but soft tissue swellings are generally single, and if they are multiple, then we have other diagnoses in mind like neurofibromatosis or generalized cysticercosis. So this information is very important in making up your differential diagnosis. What is the duration of the swelling? If the swelling is rapidly growing, then it is likely to be malignant. And if it is lying for years without increase in size, then most likely it is a benign swelling. Then history of fever or other symptoms like weight loss, weakness, malaise, pattern of fever, history of trauma or any operative procedure, history of intramuscular injections, vaccinations, etc. All these things, they help you in understanding what could be the etiology. Fever, if the patient is having fever, you may think of tuberculosis. If patient is having weakness, malaise, again the thing comes to your mind is tuberculosis. Then pattern of fever, that helps you out in saying with evening rise, suppose there is evening rise of temperature, you pinpoint towards tuberculosis as the cause of the fever. If there is any history of trauma or any operative procedure and then there is a swelling and you think that it may be repair or foreign body joint cell reaction to the trauma, or if there is a history of intramuscular injections, you may think of injection abscess, and if there is vaccination and swelling, you may think of post vaccination lymphadenopathy. Then family history is very important, particularly in tuberculosis. History of contact is a very important clinical finding. Then age and sex. Age has a bearing on differential diagnosis, particularly in soft tissue tumors, and sex is important in cases of uh, lesions in breast or genitalia. Then, once the patient comes to your FNAC chamber, you should do general examination and look for the patient's build, weight, gain, expressions on the face, which will tell you that patient is in pain, and the behavior, whether patient is irritable or cooperative or not. Then you do the local examination. What is the site of the swelling? What is the size of the swelling? Consistency, whether it is firm or rubbery or it is cystic. Then what are the margins, whether they are well defined margins or poor margins. Mobility, whether the swelling is mobile or fixed to the underlying structures or to the skin. Temperature, is temperature raised over the swelling, and whether the swelling is tender. All these points, they favor towards the diagnosis and differential diagnosis and help you out. Thorough knowledge of your subject and clinical medicine is very important in arriving at the correct diagnosis in cytology FNAC. Possible diagnosis and list of differential diagnosis should be there in your mind when you are examining the slides. Direct communication with the referring doctor is very important. You may get some additional information which may help you out in reaching the correct diagnosis. Then when we do the procedure, then we should adopt the right technique of procedure to get good aspiration material. There are two techniques which are prevalent. One is the FNAC with aspiration, or we can say with negative pressure, and aspiration FNAC without aspiration. In other words, FNAC without negative pressure or non-aspiration aspiration technique. Now here we have a swelling where the technique is being used is the aspiration technique. You insert the needle inside the lung and then you create a vacuum in your syringe, move your needle in various directions, and at the end, when the FNAC has been done, suction has been done, you bring the plunger to the original position, remove the needle, take the needle out from the syringe, and make the smear. Now, disadvantage of this technique is that there may be more blood than the representative cellular sample because of the negative pressure in the syringe. While the other technique is FNAC without aspiration or non-aspiration aspiration technique. In this, you take the needle, it may be with attached syringe or maybe without attached syringe. Advantage of attached syringe is that in case of cystic fluid, the fluid will not be able to soil your fingers. So that is advantage, and you can withdraw the cystic fluid. Otherwise, in other terms, you take the needle and put it into the swelling and move it in various directions. It is better to move in 360-degree directions and then take the needle out, attach to the syringe, and push out the material onto the slide for smear making. So the more prevalent or common technique is the FNAC without aspiration, as it yields better and representative cellular material. Then after you have done aspiration and you have received the aspirated material into the syringe, observation of that material gives you tips or ideas about the possible diagnosis. If you have aspirated blood, it is recommended to repeat FNAC from another site. But if you again get blood in your aspirate without negative pressure, then possibility is that the lesion you are aspirating is either highly vascular or it is a vascular tumor. If the aspirated material is blackish, foul smelling, and difficult to push out, think the possibility of sebaceous cyst. If the material is thick, white, flaky, think of epidermal cyst as the diagnosis. If aspirate is thick, yellow, cheesy, difficult to push out, consider this to be caseous material. If fluid is thin, yellow, pus-like, again think of caseous material as a possibility. If the aspirate is thin, white, and mucoid, then most likely it is a pyogenic pus material. If aspirate is thin, clear, watery, think of cyst like parasite or any other type of cyst. If aspirate is thick, clear, and mucoid in nature, then maybe you are dealing with ganglion or mucocele or any other cyst which is producing mucinous material. If the aspirate is thin, opaque, granular, think that you are dealing with a solid tumor. So, close observation is very necessary to get information about the possible diagnosis of the lesion you are aspirating. Now, sometimes we do not get representative material, and what are the reasons for not getting representative material? Either the needle has missed the target, or the needle has gone into the central cystic or necrotic or hemorrhagic area, and the diagnostic cells have not been aspirated. Or needle has gone into the benign mass which is lying beside, say, malignant mass, and that malignant lesion has been missed during aspiration. Or if the tumor is showing fibrotic and desmoplastic stromal reaction, then the tissue may give you scant cell yield. So you can do repeat FNAC. You can do as many as 4 to 5 passes during a single sitting. Then as far as complications of FNAC is concerned, usually it is free of complications. Maximum one comes in practice sees is bleeding at the local site with hematoma formation, and that can be treated with ice packet. In overzealous FNAC of lung, one may induce emphysema, but that also heals itself with time. Rarely, if you are aspirating a cyst which happens to be a hydrated cyst, patient may go into anaphylactic reaction. But more common is vasovagal attack, which patients may experience because of fear of FNAC. Then we have a small talk about the types of stain we use for FNA smears. The most popular stain is Meek-Grunwald Teamsa stain, and this is carried out on dried smears which have been fixed in methanol later on. Now, this method is simple and gives good idea about the cell size, nuclear size. It stains the cytoplasm and background elements and intercellular matrix. Because it stains the background and the intercellular matrix, it gives more idea than other stains, and this is a preferred stain for FNAC cytology reporting. However, some labs do use PAP stain along with GIMSA stain because PAP stain is considered superior for nuclear details. It stains various components of the cells, allows critical examination of nuclei and cytoplasmic components. It is very popular for PAP smears, but for FNAC, it is used generally in conjunction with GIMSA stain. Hematoxylin and eosinophil stain is a time-consuming and expensive stain, and results are not superior to GIMSA stain. So it is the least used method for aspiration cytology. Now we come to the reporting. Once we have aspirated the material, we examine it under the microscope, and putting all the clinical information to the background, we make the diagnosis of the lesion. And this lesion is to be communicated to the surgeon or consultant and the patient. And the These days, the priority is that the report you make should be uniformly understood in every part of the world. So there is a system of standardized reporting of FNAs which has been developed by international committees, and this is used internationally for reporting. So for reporting of aspirate smears, internationally accepted standardized reporting systems have been developed. A standardized approach with best practice guidelines. This is the aim of the standardized reporting system. To improve training in and performance of FNAB and smear making techniques. So it is not only for reporting, they guide you about the best technical practices also. They provide a basis for quality assurance measures within institutions, regions, and countries and across the international borders. So, this reporting is at par in every country and it is used internationally. It is based on a structured report. What is a structured report? Structured reporting is done in a format which uses standard headings, definitions, and includes required information. Now, what is the heading of the report? Heading of the report is where you give information about the patient's name, age, sex, the hospital from where the patient has come, the consultant doctor, their phone numbers. One should have phone number of the patient and phone number of the consultant doctor, and the investigation required means FNAC of which area. This is the head of the report, and you should give unique ID number to each and every patient. So that goes in the head of the report. Then reports use specific terminology for diagnostic categories and include a conclusion containing a specific diagnosis or weighted differential diagnosis. So there are specific terms, there are different diagnostic categories, and finally there is a specific diagnosis with differential diagnosis if required. A structured report ensures quality, clarity, and reproducibility of the reports across departments, cities, countries, and internationally. Structured reports are often based on a structured checklist. Now, what is that structured checklist? That every report must have certain points definitely, like nuclear details, the nature of the cytoplasm, the mitotic activity, the anaplasia or pleomorphism. Some points must be there in the report, and that is called structured checklist. Then acceptance of diagnosis and understanding by cytopathologists and clinicians alike. Now, this is very important. What cytopathologist is writing, clinician should be able to understand and similar to the understanding of the cytopathologist. So there has to be likeness of the understanding as far as the report is concerned. And these reports, they assist the patient management and improve healthcare and facilitate research. So that is a structured report, and that is now being practiced all over by most of the laboratories. So with that, I thank you very much. In the next talk, we will be talking about FNAC diagnosis of various organs and tissues and the way to report the diagnosis. I want to say that there are library of the digital slides which DigiScan has prepared, and this library contains sets of various subjects like histopathology, cytology, oral pathology, oral histology. So those who are interested, they can subscribe these sets available online.